And I guess in the interest of time and making sure that everybody has an opportunity to get something to munch on over the lunch period, we'll go ahead and get started. This is hopefully one of many lunch and learns to come that are being graciously sponsored by the Illinois Prescription Drug Monitoring Program. So we really do thank their sponsorship and support for trying to improve the level of safe opioid prescribing in the state of Illinois. As a quick introduction, my name is Chris Herndon. I am with the SIUE School of Pharmacy and practice chronic pain management and opioid use disorder management in a large family medicine residency program here in downstate Illinois. If I could, please go ahead and mark your calendars now for our next Lunch and Learn, scheduled for April 27th at 12 p.m. or noon. And this will be led by my colleagues at the Illinois Prescription Drug Monitoring Program, and they'll be going over some of the really cool new features that they are planning on launching later this spring and early summer for the Illinois Prescription Drug Monitoring Program. So we'll definitely look forward to that. As a quick reminder, if you are not currently muted, please do so at this point in time. And I would also like to ask that if any questions arise, this is not going to be extremely long. There is no CE tied to these lunch and learns, but it's supposed to be an opportunity for us to network a little bit, ask potential questions that may have arose in your clinical practice. And we do have members of the Illinois Prescription Drug Monitoring Program on the call in case there's anything that myself or my guests cannot readily answer as we move forward. So we'll go ahead and get rolling. As most of you are aware, the CDC came out with revised prescription opioid recommendations for chronic non-cancer pain. As most of you are aware also that the 2016 guidelines that came out from the CDC were met with, I would say, variable enthusiasm from providers. The big thing that I think came out of it was that we had, I believe, some questionable reactions, both from the provider level, the legislative level, as well as third-party payer potential barriers to our patients with pain. The 2022 update really differs or diverges from the 2016 CDC guidelines in that they have removed hard and fast limits or more exact and specific language around the morphine milligram equivalent thresholds, namely previously the 50 and 90 milligram thresholds have been removed. The other thing that they have softened the language on is the 3 and 7 day thresholds for the use of opioids in acute pain management. So that language has been softened a little bit as well. The other thing that 2022 recommendations have done is really gone into significantly more detail about how the guidelines should be applied, to which patient populations they should be applied to, and how the decision to either try wean attempts of opioids or taper strategies really need to be patient-centered and through shared decision-making. So what I thought I would do, and again, my apologies for this being kind of somewhat thrown together, but like I said, Dr. Glazer is not able to join us today due to a patient emergency. So I thought I would just go through quickly in 4 or 5 slides and make sure that if you haven't had the opportunity to review the 2022 CDC recommendations, that we're at least all somewhat on the same page. And again, this is being brought to you by the Illinois Prescription Drug Monitoring Program. So similar to 2016, the 2022 CDC opioid guidelines have broken their 12 key recommendations down into domains. And what I've done is tried to paraphrase those for you. The first domain is basically, should you or should you not add an opioid analgesic to the patient's treatment regimen? And this represents recommendations 1 and 2 from those recommendations. So number 1 is basically paraphrased as, if you are going to be in the process of treating acute pain, they recommend that you first try non-pharmacologic therapies. And if those are unsuccessful, then they recommend maximizing non-opioid analgesics prior to an initiation or trial of opioid analgesics. And again, this is for acute pain. The other thing that I want to make sure everyone on today understands is that the CDC uses kind of a modified ACIP and GRADE criteria to rank their evidence. Typically what we're used to seeing is, very, very high quality, low quality, et cetera, laid out that way in ranking the quality of the evidence on which they base their recommendations. And they've modified it a little bit to call them these different levels: type 1, type 2, type 3, and type 4. Type 4 is basically, there's little to no data that is on who is actually on in that circumstance. It's more of less evidence and more consensus or expert opinion. So recommendation 1, try non-pharm first, and then and/or non-opioid analgesics in the treatment of acute pain. That is a recommendation category B, evidence type 3. Number 2 recommendation is basically the same, but applied to chronic or subacute pain. So that would be pain that's lasting 30 days or longer. And it's very similar, that really a very tight harm versus benefit analysis needs to occur, taking into the consideration the patient's expected benefit from the medication and the potential risk that might ensue. The next domain that we have is basically making sure we have the right drug for the right patient. And that's how I kind of have been teaching students about this and our medical residents. And this encompasses recommendations 3 through 5. And then the paraphrase of each of these key recommendations is below each one. Recommendation number 3, the CDC really recommends that we always initiate with immediate release opioid formulations first when at all possible, instead of using extended release or long-acting opioid formulations. The old adage of start low and go slow certainly applies, and the CDC guidelines have embraced that as well with recommendation number 3. They believe that we should start with the lowest available dose, titrate slowly, reevaluate often. The CDC in this particular recommendation does not draw a line in the sand of how quickly a reevaluation should occur. I think from a clinical standpoint, it's intuitive to apply not only the pharmacokinetic and dynamic principles of the drug that you're using, but also the acuity of the patient and the severity of the pain that they're experiencing. Number 5, I think, is really kind of where the rubber meets the road in terms of one of the big differences from the 2016 and the 2022 recommendations. And in that, they actually say that tapering needs to be applied very carefully to the right patient. And this needs to be done with the exception of if there is a incredibly unsafe or illegal scenario occurring, that this really needs to involve shared decision-making, and by no instances should abrupt discontinuation of opioids occur, again, unless one of those 2 scenarios exist. So Really, this is where I think a lot of folks got into trouble with the last recommendations was they were either misinterpreted or misapplied, and what we would call legacy patients on higher doses of opioids may have been weaned or tapered too quickly, or weaned or tapered without having education and buy-in from the patient. The next domain is what I call, I'll see you back in fill in the blank, and this includes recommendations 6 and 7. The recommendation of 6 is basically when you have acute pain, the shortest duration of opioid therapy should be used. And this is in stark contrast to 2016, when the recommendations stated that longer than 3 days of opioid therapy is rarely needed for acute pain, and significant reevaluation and monitoring needs to occur when you get out past 7 days of opioid therapy for acute pain. The 2016 recommendations really based those finite lengths of time on a really interesting study that used 7 days as kind of a break point in their assessment, in which they looked at patients 1 year out, that had been put on opioid therapy for an acute pain condition. People who were provided opioid therapy for this acute pain for longer than 7 days had a significantly higher chance of continuing to be on that particular opioid for that same painful condition 1 year out, versus patients whose length of therapy on opioids was reserved to lower or less than 7 days. Recommendation 7 really gives some, I think, more specific recommendations on how quickly patients should be followed up after initiating opioid therapy. They say within 1 to 4 weeks. I think a lot of that really depends on what type of pain we're actually treating. You'll notice they specify here subacute or chronic pain. I can tell you clinically, we typically will do 2 weeks unless we are starting with a little bit higher dose than we normally would in a opioid naive patient. I know that some busy clinics may push things out to 4 weeks. I think that, in my opinion, that the follow-up should be very similar to what you might use in your busy practice, as if you were starting a new antidepressant for a patient who may have significant depression symptoms, and how you would consider safe follow-up in terms of that, I think could be applied here very reasonably. Again, if there's any questions, comments, arguments, or complaints, please feel free to throw them in the chat. Happy to address those, or if I cannot, hopefully one of our panel members can. So the last 4 recommendations, I'll call this domain risky business. This is where the risk mitigation recommendations come into play. Number 8 is basically the recommendation of incorporating risk mitigation strategies into your practice. And I think that it's really good that the CDC hasn't come out necessarily and written in stone what model risk mitigation strategies may look like. I know we all have different practices and different practice philosophies, but I think a healthy risk mitigation strategy in any practice, especially primary care, especially a pain management practice in primary care, would look like at least baseline risk assessment using a tool that is validated, things like the modified opioid risk tool, the SOAP-R. There's a nice one that a lot of primary care facilities like to use called the DIRE, or DIRE. And then ongoing risk assessment as well, using either a validated tool. Our favorite is the current opioid misuse measure, but other risk mitigation things that can be templated into your assessment and plan, not only to protect you, but also to ensure that we're protecting our patients. I see some things coming into the chat. Unfortunately, no CME is not provided for this particular lunch and learn. However, our same group is working on a 3-hour CE program that will be free to prescribers within the state to meet your required opioid education training that goes towards your CE for licensure and the controlled substance registration. I do not have a certificate of attendance created. My apologies to that question as well. Other risk mitigation strategies that can be used include patient-provider agreements. Please notice I don't call them contracts, but agreements or modified informed consents. The other things that can be used would be making sure that naloxone is on board. I always also look from a risk mitigation strategy standpoint to look at when the prescription refill requests are coming in compared to when we would expect them to come in, just making sure there's no red flags around that. Recommendation number 9 is, I think, what our esteemed supporters are very happy about, and that is making sure that we're utilizing the prescription drug monitoring program tool. It is a tool frequently. We look at it before we fill any controlled substance prescription, not just opioids, but any controlled substance prescription. And I think that the way that we utilize this is not as a tool for a gotcha moment, but to make sure that patients are using these medications safely, that we're not putting patients at undue risk. And also what we typically find is it gives us more reassurance that the patients that we do have on long-term opioid therapy are following what we would consider to be a safe use pattern. And so really it tends to be more so for reassuring the prescriber or the clinic that things are going the way that they should. So number 10 is basically they recommend some type of drug screening. We have a number of different toxicology screening methods that are available to us. We have point of care immunoassay. These point of care tools have really improved significantly from a sensitivity standpoint. And for some of the different drugs have improved very well from a specificity standpoint. I still recommend that if you are going to make practice-changing decisions for an individual patient based on drug screen results, that I think that we owe it to our patients to send it off for confirmation screening. Some of the semi-synthetic and synthetic opioids that I've run into problems with these particular screening tools include methadone and oxycodone. We still don't have fentanyl built into any of the point of care tests that I'm familiar with. However, we do have dip strips available that can be used along with the sample. We have those and we employ them in our practice. And hopefully some of these larger point of care manufacturers will be able to start incorporating that soon. From a confirmation standpoint, depending on the risk or the acuity of the patient, we will sometimes skip the cup with the point of care results and send the urine drug screen directly off to the lab for what we would call a reflex confirmation. So if anything is immunoassay positive, then they'll send it through either gas or liquid chromatography and mass spectrometry to really make sure that we have strong reassurance that what we see is what is there. And the other nice thing about that is we also get a little bit more information on the metabolites that might be there, and those can be very telling as well. So right now we have drug toxicology screening through obviously urine. That's probably the least invasive, least expensive, and most familiar for most of us. We have saliva screening, and there are a number of companies that produce like either a saliva swab or something where you insert saliva into like a little tube up to a certain volume, and then those get sent off to a laboratory for analysis. The third one, probably the most invasive and probably less frequently utilized, is serum drug monitoring. We sometimes will use this if we have situations we're not able to get either of the other two, or we want to get a little bit closer real-time picture of what the individual drug concentration is. We don't use these frequently, but there, like I said, there are clinical situations where we might. The recommendation number 11, again, just to paraphrase, we need to really do our very best to try to avoid concurrent prescribing of opioids and benzodiazepines. I think that's been very well spelled out in the medical literature. This is a carryover from the 2016 recommendations. And I think we've really learned a lot more about some of the other substances that can increase the risk potentially of opioid overdose, opioid-induced respiratory depression, and ultimately, and unfortunately, opioid-related overdose deaths. So CDC says really try to avoid benzos when you can. I realize that it's really difficult clinically to wean patients from benzodiazepines as it is opioids, and at least making those movements towards trying to pull back on concurrent prescribing definitely improves the risk profile for your patients. Some other medications that we've seen that can increase the risk, similar to benzodiazepines, include skeletal muscle relaxants. Those have been shown to increase some of this overdose risk. The sleep hypnotics like zolpidem and some of the similar medications can increase risk. And we're actually starting to see that gabapentinoids might increase risk, although we're really not super sure about how that has played out. The data is continuing to emerge in that area. And last but not least is higher dose antihistamines. So all of those should at least prompt you as a clinician or a prescriber or a dispenser to, at least in the back of your mind, understand that there is some additive risk when those medications are given concurrently with opioids. The other thing to keep in mind is that, with the 2016 recommendations, like I said earlier, the 50 and the 90 milligram morphine milligram equivalent was kind of drawn in the sand a little bit because of the increases in odds ratios when they pulled out some really big retrospective cohort data. I guess the easier way to think about this is any opioid increases risk, and there is a dose-related increase in risk as we increase the dose. So, 49 milligrams MME is not necessarily significantly safer than 50 or 51 milligrams. It's just the way the study was designed that they based those cut points on. Last but not least, the 12th key recommendation from the CDC opioid recommendations 2022 is that we need to be judicious in screening for opioid use disorder, regardless of severity, and we have to be ready and willing to offer treatment for opioid use disorder when we do suspect that that may be present. I have been really trying to push our providers at our family medicine residency program to become comfortable with this. I know that the X waiver was officially removed as a requirement just within the last 2 weeks, and I think that's really exciting from a standpoint of being able to provide buprenorphine containing products to our patients that need it. The other thing to keep in mind is that some of your pharmacies that may be providing services to your patients may not have updated their dispensing software yet. So for instance, yesterday we sent a buprenorphine prescription over for one of our patients, and we still were required to provide an XDEA number because their software was still forcing them to enter that before they could proceed. So you may still get recommendations from some of your pharmacy colleagues please don't take any offense to it. It's just a matter of some of the software hasn't caught up with the rules and the legislation. Another interesting thing, so I know this was supposed to be about CDC recommendations. I thought just for giggles, another document that has just come out within the last month or so is the VA and Department of Defense opioid guidelines. From a clinically intuitive standpoint, they really don't, I say, differ greatly. I mean, for those of us who are practicing in pain management and are operating in and around opioid therapy frequently, I think a lot of this stuff are things that we have been doing for years and years, even before 2016. And I think that it's helpful sometimes to take, to the best of our ability, evidence, put it behind what we're doing as we're trying to navigate some of that clinical decision-making on the fly. Now, these are really what I would consider to be paraphrased key recommendations from the VA and DoD opioid guidelines 2022. They come out and they say they recommend against opioids for chronic non-cancer pain. They recommend against long-term opioid therapy when they can, especially for younger patients, because they use their evidence base to suggest that the younger the patient, the more at risk for developing a use disorder is. They recommend against using long-term opioids for those with a substance use disorder history. In those scenarios when opioids are required long-term in somebody with either a recent or current diagnosis of opioid use disorder, they make no recommendation or have no preference on using buprenorphine, methadone, or naltrexone to manage that. Now, the thing I thought was really interesting here is that recommendation number 5. And I know that a lot of us have been incorporating this into our clinical practices. However, it's really interesting now to see a treatment guideline that's actually kind of come off the fence and said this, and that is that they recommend when long-term opioid therapy is indicated, they recommend buprenorphine over full mu opioid receptor agonist therapy for chronic pain. And to my knowledge, this is one of the first non-state specific guidelines that have really come out and made that recommendation. The rest of these line up pretty closely to the CDC recommendations. Try to avoid benzos, start low, go slow, and use opioids for the shortest duration possible. Risk mitigation always, and always make sure that we're monitoring judiciously for signs and symptoms of opioid use disorder. Follow up frequently with always keeping an eye on, are we actually meeting our treatment goals? And making sure that the risk of ongoing therapy does not outweigh the potential benefit. And the treatment goals may be very different from patient to patient. We have some patients where our treatment goal, believe it or not, is so this individual patient can walk his dog 2 blocks versus 1 block without sitting down. I've got others that when we have significantly elevated guest rates or frequent guests of our local emergency department or emergency services, that we're hoping that we can try to curtail that a little bit through the primary care setting versus having those patients use more resource-intensive situations. Okay, when we follow up, similar to the CDC, the VA-DoD guidelines really recommend that follow-up needs to occur at least or at minimum every 30 days. That tends to be, I think, a little bit quicker than what some of the other recommendations have cited as a no longer than 90 days. I think 30 days is reasonable. The problem is that when you have busy pain services, we may not be able to really get patients in for follow-up appointments that quickly. I know that we deal with that. And so there probably needs to be some sort of touch point or evaluation, even if it's just during medication renewal. And then last but not least, their final recommendation is to avoid long-acting opioid formulations when possible especially in opioid naive patients, and that they should be limited to longer-term opioid prescribing in subacute and chronic pain. So with that said, that is all I have. Quick and dirty discussion. Any comments, or does anybody want to add anything or different interpretations of how they have looked at the CDC guidelines or implemented them differently? Please feel free to put it in the chat or unmute yourself. Hopefully we can make this somewhat of a interactive dialogue. I also, while we're waiting to see if anybody has comments or questions, if I can do a shameless plug, one of our guests here on the Lunch and Learn today, Dr. Huff, is with the Illinois Prescription Drug Monitoring Program, and he is in the process and I think has launched a really nice toolkit that is available on the PMP website for which not only includes some of these kind of higher level recommendations from the updated CDC recs, but other really useful resources and educational resources for you to avail yourself of. So do I have that right, Dr. Huff? I don't know if it's...
Absolutely. Can you hear me?
Mm-hmm.
Yep, we created a few risk mitigation toolkits and sent them out quickly, and I think they were still posted, but we're making them more visually appealing, and they will be updated. Rolling basis, they'll still be available, even if they're not as pretty and branded as they will be in the future. But yes, through our website, we have access to those toolkits.
Fantastic.
And we did, they are primarily based around CDC recommendations, again, because they were fairly inclusive. Of course, the VA DoD ones are slightly different, but the CDC making some large changes, those were key points for us to bring up in those toolkits.
Very good. Just as a quick reminder, while we're waiting for potentially any other questions or comments to come in, please do mark your calendar for April 27th. One of our esteemed PMP colleagues will be presenting some of the new and exciting features that they have been working diligently on to roll out to make your life as a clinician easier and to provide safer care for our patients of Illinois. So any other comments, questions? Don't be shy, throw it out there. Recommendations? Okay. Well, barring nothing else, we're very grateful that you took a few minutes out of your busy lunch hour to join us. I hope that you found this beneficial. Once we will be creating an Illinois Prescription Drug Monitoring Program YouTube channel and library that will house these short kind of, I would call them speed dating webinars or lunch and learn webinars for you to access later or to refer your colleagues to. And please keep an eye out for the Illinois PMP sponsored 3-hour safe opioid prescribing CE that will be launched early this summer, that will have 3 credit hours of CME tied to it that will go towards your Illinois licensing requirements. So if there's nothing else, we'll go ahead and log off. Hopefully you have something delicious waiting for you to eat before we get back to it. So thanks. Hope everyone has a wonderful week, and we'll talk to you very soon. Thank you.
Thank you, Chris.
Yeah,
I appreciate you hosting this. I know that we had an emergency issue with Dr. Glazer speaking. So I really appreciate you stepping in and presenting some good info here.
Oh, no worries. So that, sorry that my slide deck was kind of thrown together. I didn't have a lot of time to get it ready to go, but we had somewhere around 50 registrants. And at the peak, I think I counted 20 on. I don't know if you looked or not.
I have not yet.
Okay, well, everybody's gone now.
Yep.
So looks like we still have a few guests in. Did you all have a comment or question, or maybe just haven't logged off yet? Okay, Eric, I did get your email about the data. I hope to get a response back to you this afternoon. Okay.
Okay. Well,
Hey,
thank you. I think we'll go ahead and end this recording. I'm also gonna follow up with you on your questions around the CE content. So